Welcome to our learning community event on cardiology and type 2 diabetes. My name is Jackie Rao, and I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. And we are very fortunate today to have Dr. Devraj Sukul here to present to us. So I will turn it over to you, Dr. Sukul.
Fantastic. Thank you so much. It's great to be with you all. Let me just get my slides to share. Here we go. Share screen. Is this one. Does everyone see my slides?
Yep, we can see it.
Perfect. All right. Thank you for that introduction. Good afternoon. It's great to be with you all. And I would love to keep this as interactive as possible, and hope to learn a lot from you all as well in this great collaborative that I already use as a resource, and hopefully I'll shed some light on some of the great resources that are available. Please feel free to drop in any questions or comments in the chat, and I'll do my very best to leave adequate time at the end to discuss those. Let me move this around. So I've been tasked to discuss SGLT2 inhibitors and GLP-1 receptor agonists from a cardiovascular perspective. I'm an interventional cardiologist here at the University of Michigan, and also work with our cath labs throughout the state of Michigan on various quality initiatives around interventional procedures. And very recently, we've been doing our best to disseminate and incorporate a lot of the great data that's come out of large trials with these two classes of medications for our patients with diabetes, and we'll touch on a handful of patients actually without type 2 diabetes, but who have cardiovascular disease that benefit from these medicines. Oh, there we go. Just a quick disclosure, as I noted before, some of my salary is funded by my role in BMC2, which is the Blue Cross Blue Shield of Michigan Cardiovascular Consortium. So this is our agenda for today. We'll speak to some evidence supporting the use of these two classes of medications for patients with or at risk for cardiovascular disease. I'll try to provide some contemporary data, particularly related to Michigan, around the rates of prescription of these two classes of medicines, and then touch on some practical tips on prescribing these medicines and leave time for questions and comments. All right. This, I like to think about how in the cardiovascular community, we are currently think about classes of medications, particularly as it relates to SGLT2 inhibitors, and how we're hoping to move forward in our goal is on the right-hand side of this bell curve. I think there's a fraction of individuals, cardiovascular providers in particular, who have no knowledge or are maybe just aware of the cardiovascular benefits, and very few that are adding it on, as you can see on the right tail of this curve. And we're hoping to move everyone more into the right-hand side of this equation through various efforts in our societies and colleges, trying to disseminate information around the benefits of these medications and really add it to our armamentarium. As you can see on the left, this is at a nexus of multiple different specialties. Primary care physicians obviously play a really important role in primary prevention of cardiovascular disease and prevention of other conditions. Cardiologists, I think, historically have kind of lived in the very specialized world of secondary prevention, or those with known cardiovascular disease, and are often prescribing lipid-lowering therapies and blood pressure medications to those with clear sequela of hypercholesterolemia and hypertension, but not necessarily focusing on the primary prevention component, frequently because they're coming to us after a diagnosis. And then our diabetes specialists, obviously thinking about metabolic syndrome in total, and maybe most facile with SGLT2 inhibitors and GLP-1 receptor agonists, given their initial approval as type 2 diabetes medications. But our hope is to shift it so that the overlap in this Venn diagram actually includes SGLT2 inhibitors and GLP-1 receptor agonists. And from a cardiovascular or cardiologist perspective, it's because these agents have been shown to reduce cardiovascular risk, frankly, to really impressive amounts, and in areas that are extremely exciting to us, because the approval of SGLT2 inhibitors or demonstration of their benefit in conditions that we frankly had no evidence for, such as heart failure with preserved ejection fraction. And I'll try to touch on that data and its incorporation into our recent guidelines, trying to at least emphasize the dramatic benefit that these medications can have. So to go over some definitions, since I'll be using a handful of abbreviations here. ASCVD is atherosclerotic cardiovascular disease. So it's those individuals with a prior history of known cardiovascular disease, usually myocardial infarction, known coronary disease, known peripheral artery disease, prior stroke, arterial revascularization. Cardiovascular disease, more broadly speaking, incorporates ASCVD, heart failure, and cardiovascular related death. Heart failure are symptoms of heart failure, which are usually dyspnea, shortness of breath, fluid overload. This is, and I'll delineate this a little further in the table on the right, has further subcategorization. So it's heart failure with reduced ejection fraction, that's an EF of 40 or less. Heart failure with improved ejection fraction, which is those with a previously reduced ejection fraction that's now above 40%. Heart failure with moderately reduced or mildly reduced ejection fraction, which is 41 to 49%, and heart failure with preserved ejection fraction, or HFpEF for short, which is an ejection fraction greater than 50%, but with evidence of spontaneous or provocable increased LV filling pressure. So the idea there being many patients, and we're frankly understanding more and more about the pathophysiology of HFpEF as time goes on, but kind of generically speaking, can think of it as those with hypertensive heart disease or other conditions that stiffen the heart or impair its relaxation, that thereby increases a person's sensitivity to fluid and volume, usually making them short of breath, either at rest or in many cases with exercise. Filling pressures go up, and we can make those diagnoses with right heart caths or exercise right heart caths, as well as some parameters on echocardiography. And then finally, patients who are high risk for ASCVD. And that's important because some of these medications enrolled, or some of these trials enrolled patients who are at high risk for ASCVD to demonstrate a reduction in hard cardiovascular endpoints as part of their trial endpoints. And I'll touch on this, and I've tried to include references to in each of my slides that I've borrowed from either colleagues of mine or from publications. This is, I think, a really important one that I go to frequently from a cardiovascular standpoint, is the ACC expert consensus decision pathway for these therapies among patients with type 2 diabetes. So we'll start with sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors for short. They, similar to GLP-1 receptor agonists, have pleiotropic benefits or pleiotropic effects that ultimately lead to their pretty dramatic benefits, not only in terms of diabetes management, but in terms of reduction in cardiovascular and kidney endpoints. There are kind of 4 major drugs and more coming to market with these, as most of you are probably aware of. The initial labels were for glycemic control in type 2 diabetes. 3 of them have additional labels for cardiovascular risk reduction in type 2 diabetes. And then there are also additional labels for CKD or heart failure, and we'll touch on the specific medications for those. But there's likely a class effect, even though not all the medications in the class have been tested for each of these endpoints or each of these specific conditions, as we'll touch on. This is taken from that reference I had shown earlier, really summarizing some of the major trials of SGLT2 inhibitors with cardiovascular and renal endpoints. These were empagliflozin, canagliflozin, and dapagliflozin, sorry. And as you can see at the top, their dosing. I think most importantly, you can see our MACE outcome, which is a composite outcome of major adverse cardiovascular events. Differs slightly in each trial, but generally can be thought of as cardiovascular death, stroke, MI, and in some cases, heart failure hospitalization. I think its most dramatic benefit is in a reduction in hospitalization for heart failure or cardiovascular death, as you can see with hazard ratios ranging between 0.6 to 0.9 in all these trials, cardiovascular death reduction, and importantly, heart failure hospitalization. Not only is heart failure hospitalization a very common outcome amongst patients with and without heart failure, or so prevalent heart failure and incident heart failure, it's also quite costly to the healthcare system, and it's been shown to be an adverse outcome for patients. It tends to be indicative of prognosis among individuals with known heart failure. And then finally, you can see a renal composite endpoint reduction. I'll touch a little less on the renal benefits of these medications, given the task at hand in speaking with the cardiovascular benefits. Suffice it to say, SGLT2 inhibitors have really dramatic benefits on multiple organ systems with hard cardiovascular endpoints and renal endpoints in their trials. And I think have now been very elegantly incorporated into multiple guidelines, including our cardiovascular guidelines, but also the ADA guidelines. Quick summary of the SGLT2 and heart failure trials. I think initially they were tried in our heart failure with reduced ejection fraction population, the ones we kind of classically consider as having heart failure with an EF less than or equal to 40%. Sorry, I take it back. The DELIVER trial should actually read heart failure with mildly reduced or heart failure with preserved ejection fraction. That was a typo in the DELIVER trial here. So 2 heart failure with reduced ejection fraction trials, heart failure with mildly reduced and preserved ejection fraction in DELIVER and EMPEROR preserved. And then the SOLOIST trial kind of incorporated all ejection fractions over their time period, but really picked up people who had worsening heart failure or hospitalization for heart failure. So trying to catch people as maybe they're declining or have demonstrated evidence of decline. And in all these trials, in this nice meta-analysis by Vaduganathan et al., really demonstrated a reduction in cardiovascular death or heart failure hospitalization that was seen across all trials, across all subsets of LVEF, with a hazard ratio, combined hazard ratio of 0.77. In cardiovascular death, again, maybe not significant in each of the trials, but the overall benefit in this meta-analysis was at 0.87. So taking advantage of the power gained by combining the trials really demonstrates reductions in cardiovascular death or heart failure hospitalization, as well as cardiovascular death overall. So this is important because this is irrespective of a patient's diabetes status. And that has led to, frankly, SGLT2 inhibitors being a game changer for the management of heart failure. And I think I'm most surprised and most impressed by its incorporation into the guidelines for heart failure with preserved ejection fraction, which I'll touch on in just a second. This is our new heart failure guidelines, which is patients at risk for heart failure, which is a large amount of the population, as you can see by how we define being at risk. Those with hypertension, since hypertensive heart disease is still the most common cause of heart failure, patients with type 2 diabetes and cardiovascular disease or high risk for cardiovascular disease, and then patients with cardiovascular disease, known cardiovascular disease, who maybe haven't demonstrated heart failure yet. Those with type 2 diabetes and documented cardiovascular disease or high risk for cardiovascular disease have a class 1 indication for SGLT2 inhibitors, as they prevent incident heart failure and hospitalizations for heart failure, as demonstrated in the tables previously. When we stratify it by the classification of heart failure based on ejection fraction, you can see the class 1 indications for heart failure with a reduced ejection fraction in terms of pharmacotherapy. For those with an EF less than or equal to 40%. 5 class 1 medications, 4 that should be started kind of right away, which is Entresto or an ARNI in those with NYHA class 2 or 3 heart failure, or ACE or ARB in those with 2 to 4 heart failure, class 1 indication. Beta blocker, again, very important that it's those with a reduced ejection fraction that should be on a beta blocker. As was alerted to me to emphasize, beta blockers can be can increase one's weight, obviously have side effects of fatigue, so should not be placed for those with an EF greater than 40% if there's not another indication. Mineralocorticoid receptor antagonists, SGLT2 inhibitors, and then diuretics as needed for symptom control. So SGLT2 inhibitors, class 1 therapeutic. For those with mildly reduced ejection fraction, the strongest level of evidence is for SGLT2 inhibitors at a class 2A recommendation. Diuretics, again, are as needed for symptom management as class 1. But of those 4 evidence-based therapies that should be started on ACE or ARNIs, beta blockers, MRAs, and SGLT2 inhibitors, for those with mildly reduced EF, SGLT2 inhibitors have the strongest evidence base. And for those with EF greater than or equal to 50%, again, 2A. So frankly, for anyone with heart failure, SGLT2 inhibitors are being started, and that's a clinical diagnosis of heart failure irrespective of their ejection fraction, which is frankly a game changer because it's not for the lack of trying with these other medications to prove their benefits in those with heart failure with preserved ejection fraction. So courtesy of my one of my heart failure colleagues here, Tom Casino, all 4 drugs should be started. How to do it is a little less certain, and this is for, again, patients with heart failure. We have this sequencing here. This is for those with reduced ejection fraction. Conventionally, we've been starting ACE ARBs or then beta blockers, then mineral MRAs, and then replacing their ACE or ARB with an ARNI, which can be a complicated transition. And then lastly, SGLT2 inhibitors. I think the updated proposal here is to try to initiate combination therapies where most of our heart failure doctors are actually starting with SGLT2 inhibitors, frequently because it's the one with the least hemodynamic effects. And although it does have a natriuresis phenomenon and can decrease weight loss and sometimes requires a reduction in an individual's diuretic dosing, it's otherwise very well tolerated and really has no hypoglycemic effect, particularly amongst those has no hypoglycemic effect, clinical hypoglycemic effect amongst those without type 2 diabetes. And its benefit from a hypoglycemic standpoint or glycemic standpoint in type 2 diabetics has clearly been shown. And so this is the new sequencing that most heart failure doctors are leaning towards. Some are actually trialing all 4 medications at once. I personally tend to do it this way, with the beta blocker and SGLT2 inhibitor, and then sequentially over the course of the next 2 to 4 weeks, every week, trying to add on another therapy and then get them to target doses. A quick summary of SGLT2 inhibitors with FDA-approved benefits by their condition. The top 4 rows are those with type 2 diabetes, and the columns here across the top are the 4 SGLT2 inhibitors. I'll note here the chronic kidney disease nephropathy. Dapagliflozin has the strongest data available for reduces in end-stage kidney disease, worsening kidney function, and then cardiovascular death, heart failure, hospitalization. Again, those with CKD with or without type 2 diabetes. For those with chronic heart failure with reduced ejection fraction, we've seen it studied in empagliflozin and dapagliflozin, preserved ejection fraction, dapagliflozin studied it as well. And then there was a question that was posed before we started about whether we're going to see it started amongst patients after an acute MI, a question that I find fascinating as an interventional cardiologist. I think there's likely going to be benefit just based on the mechanism of action and its seen benefits in those at risk for or with diagnosis of heart failure, but we haven't proven it yet. It has not been studied in this context, but will be studied moving forward. This is the postulated mechanism by which it'll likely be beneficial or believed to be beneficial amongst patients with myocardial infarction, amongst patients with and without diabetes, and from a cardiovascular and kidney standpoint. And these are the 3 ongoing trials that have yet to be published, as far as I'm aware, in terms of the benefit of empagliflozin and dapagliflozin for patients with myocardial infarction. Some practical considerations when starting these medications. You can see here, I'll touch on a handful of these potential adverse effects quickly. Canagliflozin is a P-glycoprotein substrate, so can have some interactions with other medications, including digoxin, which is infrequently used and obviously more frequently used by cardiologists, but something to keep in mind. Genital and urinary tract infections, something to obviously counsel your patients about perineal hygiene, what to look out for. The fungal infections can be treated if they're noted. Importantly, there's no significant increased risk of urinary tract infections, kind of bacterial urinary tract infections in particular, but something, again, to counsel your patients about and speak with. Hypoglycemia is generally thought to be uncommon. It's concomitant use with sulfonylureas, and insulin can certainly increase the risk of hypoglycemia. Again, it should be noted that these SGLT2 inhibitors are indicated for patients with type 2 diabetes, not type 1 diabetes. Obviously, you want to ask about a history of ketoacidosis, and wouldn't start those in patients with a prior ketoacidosis. Want to counsel them on the symptoms of ketoacidosis, and also know if they're taking a low carb diet, which may already be a diet that's increasing ketosis. And the addition of SGLT2 inhibitor may increase ketosis as well. Renal injury, there is an expected decline in eGFR of about 3 to 4 milliliters per minute. Most eGFR thresholds are less than 30. Empagliflozin recently, for the use in patients with heart failure, so not with type 2 diabetes, but with heart failure alone, I think they've changed that to can be safely started in those with an eGFR greater than 20. So they changed the limit, but for that very specific subpopulation. And then volume depletion just should be counseled about, can increase risk with concomitant diuretic use. Depending on if I believe the patient's euvolemic or on a really high dose of a diuretic, I'll sometimes preemptively reduce their diuretic, but more often than not, I'll simply ask them to get in touch with me in the next kind of 5 to 7 days about what their weight has done. And then I'll usually check labs within 1 or 2 weeks of starting. And then for my practice generally is I'll check it at 1 week, 1 month, 3 months, and then if that looks good, usually every 6 months for patients with heart failure. That's kind of been my use. And I extrapolated a little bit of that from how I check potassium in patients who I start on an MRA. All right, GLP-1 receptor agonists. And I'll be honest with you. I prescribe these a little less, and I'll speak to a little bit about my apprehension, just my personal apprehension in counseling and speaking about injectable medications. Nevertheless, I think this fantastic consortium here has some really great resources that have obviously pushed me to begin to prescribe it and counsel patients appropriately about how to use it, its risks and benefits. Similar to SGLT2 inhibitors, a pleiotropic effect throughout the body, given the role of insulin in energy metabolism for multiple organs.
Dr. Sukul, before we move on, there was a question in the chat.
Oh, sure.
In your experience, do you find that it's common patients can't tolerate beta blockers and SGLT2s due to hypotension and/or can't get patients to target doses?
Great question, and thanks for letting me know. I lost track of the chat, so thank you for jumping in. I have not seen that. Now, some of it depends on what beta blocker. Beta blockers in general are not great antihypertensive medications, and I tend not to use them for the treatment of hypertension alone. If they're already hypotensive, then any of these medications can have a challenge in terms of blood pressure reducing effect. But of the 4, let's say for those with heart failure with reduced ejection fraction, which have a class 1 recommendation for 4 classes of drugs, SGLT2 inhibitors are the least likely to cause hypotension of that 4 class regimen, with ARNIs and ACE inhibitors being the most likely, followed by actually MRAs in that population, like spironolactone, don't actually have a dramatic antihypertensive effect. For patients with heart failure, hypotension for me is symptomatic hypotension. I'm frequently trying to get people in tolerating blood pressures of systolics in the 90s to low hundreds. It may be alarming to a patient, and that's where I think counseling is important, particularly in heart failure, for counseling for a lot of different things, which our heart failure doctors do a really fantastic job about, but I think cardiologists in general spend a lot of time on. But I haven't seen this combination being poorly tolerated. I usually start at the lowest dose. I'm more familiar, just my prescribing pattern has been a little bit more empagliflozin just from a comfort standpoint, but all of them have great benefits. And so you should feel free to prescribe any of them. So I'll start with 10 milligrams. And that's actually the dose that's recommended for purely the indication of heart failure. You don't try to up-titrate to 25 unless they have type 2 diabetes or another indication. And then I'll usually start the lowest dose of either metoprolol, succinate, carvedilol, or bisoprolol, which are the 3 primary beta blockers that have evidence for heart failure with reduced ejection fraction. With carvedilol, maybe theoretically having the greatest blood pressure effect, given that beta 1 and beta 2 blockade, with metoprolol having less of a blood pressure effect than co-reg, but they're both pretty marginal blood pressure effects. So based on your proposed order of initiating meds, you have been starting SGLT2 inhibitors before. Sorry, the chat box isn't that open. You've been starting SGLT2 inhibitors before ACE ARBs. Yeah, good question. So it depends a little bit on their blood pressure, and many of these patients are already on an ACE or an ARB, so I obviously don't change that. I have been trying to start SGLT2 inhibitors as kind of right away, and I'll frequently start, if tolerated, an ACE or an ARB. I think many of our physicians are usually, it's unlikely that any of these patients are not on one of those 4 classes. And so there's not a correct order. There's just that proposed pathway. But I have no problem with prescribing an SGLT2 inhibitor, given that their side effect profile is very favorable compared to the other medications, given the hypotension that can ensue from ACE and ARBs, as well as MRAs and beta blockers. I don't know if that answers your question. My problem isn't side effects, it's the out-of-pocket cost. Even after spending hours to get authorization, which means that the script will only be about 100 until there's an easy way to determine the cost for the patient. Most of these medications pre-approved, to be honest. I feel like I'm wasting my time and money. That is a great point. Great point. And I commiserate with you fully. I will provide some of the resources, which I'm sure you're aware of or your team is aware of, that I think we have available. I think it requires us as healthcare professionals that see patients and realize the benefits of these to continue to petition our insurance companies about the utility and the dramatic benefit of these medications. But yeah, there's no easy way. I tend to counsel my patients, though, that I am prescribing this. It may go through, the pharmacy may run it and fill it, but when you go pick it up, if that copay is whatever it is that seems really, really high, you don't have to pay for it. You can call us and we can talk about alternatives. And then frequently we'll go through either trying a different medicine to find out which one's on formulary, or having our team call the insurance company to sort it out. And then there's obviously patient assistance programs available as well. But I share your frustration and the feeling of wasting time and money. No, I fully realize $100 is the copay. And if it's $100, and for the vast majority of patients, that is cost prohibitive, particularly for a chronic medication, I will tell them not to pay for it, and we'll look to see if there are alternatives or if we can file for the patient assistance program. All right, great. Keep the questions coming, and if I lose track of them, please feel free to interrupt. So going back to GLP-1 receptor agonists, these MACE outcomes, as we discussed before, were reduced in the vast majority of the trials. Cardiovascular death in liraglutide and semaglutide subcutaneous. The semaglutide oral did show a reduction in cardiovascular death hazard ratio, but not in, from a significant standpoint, not in the other endpoints that have been trialed. Long and the short of it is liraglutide, semaglutide subcutaneous, and dulaglutide are the ones, I believe, with a FDA indication for type 2 diabetes and cardiovascular disease, or at risk for cardiovascular disease. And we'll talk about when to choose, maybe start one over the other amongst patients with type 2 diabetes in a couple slides coming forward. This is a nice meta-analysis published in Lancet in 2021 of the very large trials amongst patients with type 2 diabetes And you can see the combined benefits demonstrating reductions in MACE, mortality, heart failure, hospitalization, and kidney outcomes without an increased risk for severe hypoglycemia, retinopathy, or pancreatic adverse events effects as well. Some contraindications to be aware of: severe renal impairment or end-stage renal disease, personal family history of medullary thyroid cancer, and MEN2 syndrome. Important to discuss those. Can have a hypoglycemic effect with insulin, sulfonylureas, and glycides. Should be really cautious about its prescription amongst patients with prior gastric surgery and bariatric surgery, given that it can delay gastric emptying. And then adverse effects to monitor for: nausea, vomiting, diarrhea, hypoglycemia, as we noted before, weight loss, which is an adverse effect but can be used to one's advantage in treating patients with obesity and type 2 diabetes, as most of you are aware of. I took this from our 2020 expert consensus because as cardiovascular physicians, I think more and more of us are aware of the benefits of these classes of medications. However, we're still not at a place where, from an implementation standpoint, we're achieving patients on these classes of medications at a meaningful amount, and I'll share some of that data. But I'll tell you, at Michigan Medicine and through the work we do at BMC2, we've started some initiatives about trying to increase the prescription, or at least the recommendation at a minimum, of these medications among patients with type 2 diabetes who we've put a stent in, new diagnosis of cardiovascular disease and type 2 diabetes who aren't on these medications. We've been trying to at least increase the likelihood that physicians become aware of the benefits, even prescribe it, or at a minimum make a recommendation so their outpatient cardiologist or primary care provider can kind of take over and begin prescription of these medications. Some considerations about what to start first. For MACE prevention, both classes of medications are quite good. For heart failure prevention, SGLT2 inhibitors have data supporting its use. For weight loss, maybe GLP-1 receptor agonists, you choose that over an SGLT2 inhibitor. For renal disease progression prevention, SGLT2 inhibitors more than GLP-1 receptor agonists. And then mode of administration is important too. Patients may clearly have a preference of an oral medication over a subcutaneous injection. And I actually think visually these guidelines are fantastic. These are from the 2020 ADA guidelines. And so for patients with type 2 diabetes, first-line therapy is metformin, comprehensive lifestyle change. And then if you're at high risk or established ASCVD, CKD, or heart failure, you would consider these class of medications independent of their A1C. So if ASCVD predominates, and that's age greater than or equal to 55, coronary carotid or lower extremity artery stenosis greater than 50%, or LVH, so kind of end organ sequela of hypertension, smoking, diabetes, etc. Maybe preferably choose a GLP-1 receptor agonist with proven cardiovascular benefit. Versus if heart failure or CKD predominates, you probably have greater evidence for an SGLT2 inhibitor as being the first medication you initiate, with very quickly, if your A1C is still above target, adding the other medicine. So if you start a GLP-1 first, add an SGLT2, and vice versa. With the specific medications listed here, those with proven CVD benefit. So how are we currently doing with SGLT2 inhibitors? And this is specifically for after PCI across the state of Michigan. All patients are in kind of the gray bar, and diabetic patients are in the light gray. I would focus purely on the diabetic, the patients with diabetes mellitus. We are increasing over time, which is fantastic. I think that's not only indicative of maybe us in interventional cardiology doing a nice job of prescribing and or recommending it, but maybe more importantly about the general increased uptake over time of these class of medications, with a real increase in 2021. And hopefully this prescription rate continues to go up. If you can imagine, just 2 years ago, we were less than 10%, and now we're almost 20%. GLP-1 receptor agonists, slightly slower uptake, but similar trend in the last 4 to 5 available quarters of data that we look at, now reaching almost 14% And our hope is over time, this continues to increase as more and more cardiologists, but I think physicians across the board are becoming familiar with the benefits and how to prescribe these medications. So some questions for the audience that we have here. Some practical considerations of coordination of care between PCPs and specialists. How would you prefer a patient's cardiologist to handle these two classes of medications among patients with type 2 diabetes mellitus? You'd prefer the cardiologist to prescribe the medication first, would prefer the cardiologist to make recommendations about prescribing. And if the cardiologist does prescribe these medications, would you prefer the cardiologist to continue prescribe the medication or transition follow-up to primary care, with one being continued prescribing versus transition follow-up to primary care? Can we post that poll question? I don't know if I have the ability to.
Yep, I will launch it right now.
Perfect.
Both questions are going to be at the same time, though.
Sounds good. Jackie, will we get a pop-up of the final?
Yep, I'm watching the results come in, and once they slow down a little bit, I will end the poll and then display results to everybody on the call.
Awesome.
Still having a few answers coming in, so I'll give it just a couple more seconds. Okay, do you see the results on the screen now?
Yeah, great.
Perfect. If you want to talk through this.
Yeah. So near 50-50 split on preference of prescribing the medication. The answer for the first question, I would prefer the cardiologist to prescribe the medication first, 49%. I prefer the cardiologist to make recommendations about prescribing, 51%. How many do you have the number of people that voted? Actually, I'm actually gonna take a picture of this because I speak with a group of cardiologists soon, so I think this might be informative for all parties involved.
53, and I will take screenshots of this and send it to you.
Thank you. That'd be great. And number two, if the cardiologist does prescribe, would you prefer the cardiologist to continue to prescribe medication or transition follow-up to primary care? Continue prescribing is 26%. Transition follow-up to primary care is 74%. So that the majority suggests transitioning follow-up to primary care. We have here, change my vote, cardiologist do the initial legwork, getting authorization. So that is important. When they hear it from me, it is just a PCP recommendation, which they feel free to disregard or discard, sorry. Gotcha. No, that's very helpful. Could I know we don't have a free form text, but I'm curious, I would love to hear people's thoughts about what would be the best way to communicate with and or transition follow-up to primary care. Would it just be through our notes, or have our clinic call the PCP's office and ask that they move over? I mean, I think many of our patients don't necessarily see their cardiologist and their primary care physician in the same health system, or obviously the same practice. So I'm curious how that communication from our primary care physician's perspective would be best received or best to occur. And I'll try to keep track of that as we finish up the discussion here. All right. So some practical considerations, education and copays. As alluded to here very appropriately, some of the major barriers to implementation and actual utilization of these medications are financial and resource. I don't want to undermine how busy everyone is in clinic, and going through prior authorizations or prescribing a different one to find out what the copay would be can be really challenging. I think the Michigan Collaborative for Type 2 Diabetes here is a phenomenal initiative focused on an incredibly important population of patients who could stand to benefit from not only these two classes of medications, but very clearly further education of physicians and patients alike, and try to overcome many of the barriers which are preventing them from receiving the full benefit of these classes of medications. I was so happy when I found out that these resources were available. I go to them frequently, not only for my own education and benefit or reminder of all the things we need to know about these medicines, but also as something to pass along to patients. This single-handedly increased my prescription of GLP-1 receptor agonists, given that I could learn how an injectable drug was frankly taken, since in cardiology, other than PCSK9 inhibitors, we don't really use injectable medications that frequently. But also I could pass along this link and great video for our patients to look at as well. At the bottom, that you can see the patient assistance program and medication copay savings card programs that are available. Similarly for SGLT2 inhibitors, really, really invaluable information on a one-pager, albeit dense. It's all there for your own review, for you to walk through with your patient. And I have these kind of saved on my computers and as dot phrases for my notes, so I can quickly reference them while I'm seeing a patient. These aren't perfect, and they're not for obviously necessarily indefinitely, but they can help at least bridge some of the gap for these medications, as alluded to, financial barriers being important. And they also have a very nice, very straightforward clinician aid about how to think about using these medications. Obviously, clinical judgment is incredibly important, shared decision-making about what the patient's actually going to take, be it from an affordability standpoint or from a oral versus subcutaneous injection standpoint. But heart failure, CKD, and albuminuria, ASCVD, or high risk for ASCVD, and BMI greater than or equal to 27, you can kind of pick maybe one class of drugs over another, or one specific drug. Thank you so much. I think we've left hopefully adequate time for discussion or to put forward more things in the chat. I'm just going to catch up a little bit. Be helpful to state clearly in the note that med is being transitioned to PCP care with any further recommendations on dosing. That is very helpful. Patients always ask me for their refills anyway. It's just hard because we see them when they have complications or new issues and need to adjust meds frequently, even when started by someone else. I think call to office or some form of direct communication would be important, because often it's not clear to me or to the patient when it's most appropriate, when med can or should be refilled by primary care, for example, antiarrhythmics. Thank you. Fantastic. Obviously, I cannot speak for all cardiologists. That goes without saying. I think I'll tell you, my practice has generally been, if I'm using these medications for a type 2 diabetic, I will tend to reach out to the primary care physician, certainly in my note that I'm prescribing it, and for the indication type 2 diabetic with ASCVD or type 2 diabetic with heart failure, and reach out to the primary care physician to communicate that, as well as its continued prescription. When my personal practice has been, when I'm using an SGLT2 inhibitor for a patient with heart failure who does not have diabetes, I tend to continue prescribing it, given that I kind of view it under the purview of management of their heart failure, which I'm prescribing other medications for frequently. And then for antiarrhythmics, I guess I'm not surprised, because I know primary care physicians deal with so many issues, that you would be asked to prescribe an antiarrhythmic, or refill an antiarrhythmic. But that this is why these dialogues are important, because I'm often completely naive to or unaware of many of the challenges faced by my colleagues, and vice versa, I would imagine. If you are able to notify us in your note, that should be sufficient. Does anyone happen to know, does BCN and BSM have the same coverage? I do not know offhand. I believe this great collaborative has and I didn't save it here, but has a very nice table. Correct me if I'm wrong, Heidi, or Jackie or anyone else on the call who may know, but I think one of your resources had a very nice coverage table.
Yeah.
And I didn't pop it in a PowerPoint slide, but if we want to, we can go to that to help people kind of get a sense of coverage.
Yeah, I was just going to add too, it's plan specific for those two. And that is a document that MCT2D is updating quarterly. So we are constantly updating it as we get the information.
That's
I'll
fantastic.
find the link and put it in chat.
You know, I will talk a little bit about some initiatives that we've started here. You know, one of them in BMC2 across the strait, we've encouraged our providers to at least make a strong recommendation amongst patients with type 2 diabetes who've now gotten a stent for coronary disease to make that recommendation of the benefits of these two classes of medications. Some of my cardiologists, just informally in speaking with cardiologists around the state, some are very facile with prescribing these medications and kind of have their clinic sorted so that or their clinic set up from a process standpoint to try to get these started in their patients. And then at Michigan Medicine about 7 months ago, maybe longer, Heidi, correct me if I'm wrong, probably longer now, we've started this pathway for patients with type 2 diabetes who've undergone PCI. For anyone who gets a stent, we see them in a virtual visit a week later. And at the time of discharge from the stent, we talk about the importance of these medications, but at the virtual visit, alert comes up in our Epic system that states this patient has a new diagnosis of ASCVD and has type 2 diabetes, and also has a primary care physician practicing in the Michigan Medicine organization. And we have the benefit of having fantastic pharmacists like Heidi here and the really great group who we've been able to work very closely with, and they've been incredibly enthusiastic about partnering with us in trying to get these patients on these medications. And within their practice paradigm, this referral gets sent to the outpatient pharmacy group that's attached to the primary care provider, and they kind of take it from there, not only from a diabetes standpoint, but from many other chronic conditions like hypertension, hyperlipidemia. And hopefully we'll have some of that data soon, I think. Heidi, do you want to speak a little bit to that?
Yeah, so we started last July. We are analyzing data as we speak. So hopefully before our second year resident finishes up her residency, we will have some data to share and then certainly write up over the summer. So I'm hoping by fall we'll have some good information to share.
And, you know, I think there's two ways to view that. One of it feels like maybe cardiologists are abdicating part of their responsibility to the primary care physicians. I kind of view it as the natural next step in the field moving, in that one, we should be communicating, and I think as has been demonstrated by the sentiments in the chat, communicating much more closely with our primary care physician colleagues and the care teams that are responsible for taking care of these patients who often are seeing multiple specialists given their multiple conditions. So I think this helps that pathway. But two, it frankly increases the familiarity of our own cardiovascular clinicians with these medications. And simply kind of telling my colleagues that you should be prescribing these, one, is not enough because it hasn't been enough. And two, our patients shouldn't suffer from the lack of us moving that. So if we can develop processes or systems to ensure that that happens, that's fantastic. And the last thing I'll leave you with is there was a fantastic functional implementation trial published in Journal of American Medical Association, or JAMA, just a couple of months ago. I think it was presented at our ACC conference in March, that really randomized cardiology sites to implementation scientists and various audit and feedback mechanisms to improve the prescription of SGLT2 inhibitors as well as antihypertensive and cholesterol medications, and really demonstrated that it can happen with certain quality improvement initiatives focused on increasing prescriber rates of these class of medications, and ultimately will lead to the downstream benefits to the patients of reduced adverse clinical outcomes.
Well, it's cool to make catalyst.
Other questions? Those are fantastic. Lauren writes, I feel like many of my patients see an NP or PA, not a doc for heart failure follow-up. I agree, it would be nice if primary care managed uncomplicated heart failure to take advantage of our workforce. I mean, the truth is, I think a part of the reason I brought it up here was I think it's fascinating that SGLT2 inhibitors have the strongest evidence base for heart failure with preserved ejection fraction, heart failure with mildly reduced ejection fraction, compared to the other mainstays of pharmacotherapy for heart failure with reduced ejection fraction, and really is a game changer for us in cardiology, especially given the safety profile of starting an SGLT2 inhibitor. And so if you're, I bring it up to equally make all the primary care providers and physicians on this call that and healthcare personnel that these are important for your medication. So if you see that a patient with heart failure with preserved ejection fraction, for example, which are on the order of millions of patients in the United States, and they're not on an SGLT2 inhibitor, you should obviously feel empowered to reach out to their heart failure physician or cardiologist, and or take advantage of starting this class of medications. Given I would argue, I think our primary care physicians are much more facile and comfortable with prescribing these medicines than our cardiologists are. Hopefully that'll change over time, and everyone will be equally very comfortable with prescribing these medicines. But at the moment, I doubt that we're there yet. Other questions? I am at these slides would be fine from my end to be available. I can speak with Jackie offline.
Great, thanks so much. We'll plan to distribute them to everyone then. Thanks, Dr. Sukul.
Sure. Other questions or comments or Can I ask a quick question to the I should have made this a poll question because I think as interventional cardiologists we're curious. If I had to put the recommendation for these class of medications after I performed a stent on a patient who's come to the hospital, or patient who's undergone a stent, whether they are an outpatient or an inpatient, would you prefer that recommendation be in the cardiac cath note recommendation? So at the very end where we say we implanted X and Y stent, they should be on aspirin Plavix, and then right after that? Or would the preference be on the discharge summary?
I can make you a new poll actually live. I tried to capture it. Right
cool.
now I just have, would you want the recommendation in the cath note or the discharge summary? Is that okay?
Yeah, sure.
All right.
Or both. Can you write both?
I sure can. Give me just 1 second. Do you want me to include any other details in the question? I know you just went over it. No. Okay.
I just sense everyone's willingness to chime in the chat what the answer is going to be, but
okay, here it is posted. We're getting some responses in. I'll give it a few more seconds and then share them out. Do you have any predictions before I share the results, Dr. Sukul?
I think cath note is going to be like 0%, and it's going to be both in discharge summary. But I'm cheating because I'm also following your chat. So.
Oh yeah, well that was a fantastic prediction. You were exactly right.
Got it. No, this is very helpful to me, and I will then disseminate to the interventional cardiologists around the state that we are fortunate to interact with, and so hopefully, between the two consortia, we can improve communication as well as utilization of these class of medication. I think at the cath lab notes, I do not get discharge summaries, but they do all me. What does all mean? Like oh, call me. Got it. All right. Useful to know. Well, I appreciate everyone taking an hour out of their day and for the great participation in the chat and the polls, and obviously the opportunity to pass along some of this information, but equally importantly to learn from all of you, and hopefully this will lead to improved care.
Thank you so much. We really appreciate you being here and leading this talk. It was really helpful and great discussion.
My pleasure. Right. Hopefully at the end, I think at the end I put my email. Yeah, I did. So feel free to email me with any questions. You're also welcome to call. But email may be the actually more effective way to get a hold of me. All right. Thanks, everyone. Have a great rest of your Monday.
Thank
Thank
you.
you.